right, so I think we talked a little bit about holidays, where we just had the Thanksgiving holiday. It was on a Thursday, right? And no class. So we have 3 weeks of class tonight and 2 more weeks, and then we have the holidays. Yay! So we're actually going to be getting through 3 intense assignments these next 3 weeks. So by the time the holidays come around, you'll be happy for another break. And then we'll go through January and we'll have a February break. So then we'll have, 4 or 5 maybe weeks. And we should, I think I figured it out, we should be done by mid-March, around that time frame. Yeah, just about. So tonight is chapter 15. It is all about E&Ms. And I did load the textbook answers on Evolve. So what I will ask everyone to do is maybe check their answers before coming to class for the next session. And any that jumped out at you that just were like, how did they get that answer? Come to class with that question so that we can walk you through it, okay? And the workbook answers, I have a little tough time trying to get those up there. So give me at least till the weekend to get those workbook answers up there. Are there any answers right now gnawing at any of you about, did I get it right, or how did that answer come up? Anything from the homework you had to do over the last few weeks? Shauna? Yes. Daniel?
Nothing in specific, but I would like to be walked through 1 or 2 of them.
Yeah. And Darcy?
I don't think so, not right now.
Okay, so when we sent you home last week with 13 and 14, you felt pretty good afterwards?
Yeah.
Okay.
Yeah.
All right, so then, as I said, the answers will be posted up on Evolve. You can access those and then go over your answers. I will at least go over, the review and practical in the textbook, but where the workbook has so many answers to it, I'll let you look at those online and then come back if you have any issues. We'll definitely go over some reports.
Can you just explain where you're going to post them on Evolve?
On underneath course content, you'll see a section that says answer keys.
Okay.
I tried to make it real simple, so you don't have to go searching. And then once you open up answer keys, it will say textbook and then one for workbook. Okay? And that might free up some of the time to go over some of these exercises more in depth, especially the reports. And I know how everyone loved the E&M homework assignment. Okay. All right. So let's start with opening your CPT book. So we're starting in our CPT book. And we're going to open up to page 4. And it's right to the Evaluation and Management Services Guidelines. Now remember, we learned before break that before every section, you have a set of guidelines. So if you want to be taking notes and highlighting and underlining stuff, this is where you want to be doing that as I go through the presentation. Now, you're probably saying to yourself, like, what does she mean? What would I even want to highlight in there? When you're coding and when you're sitting for your national exam, you want the stuff to stick out at you that you're going to need to know as you're doing the exam. So, what are classification of E&M services? Well, off the top of your head, would you know that there are office visits, hospital visits, and consultations? No, because this stuff is not to be memorized. Will you eventually memorize it? Yes, because as you work with it, you will memorize what you work with the most. So what you want to highlight right underneath at classification of evaluation and management services, in that first sentence, the last three things: office visits, hospital visits, and consultations. Because you want those to stick out at you if you have to go looking in your book for your exam. They might ask you, what are the categories divided into for the E&M section? And you want to, if these three are one of your multiple choice, you want to know where to find it. Okay, and then most of your categories are further divided into what? Subcategories of your E&M service. And then they give you what those two subcategories are. They're office visits. Well, what kind of office visits? New patient and established patient. And then we have two subcategories for hospital visits. Well, what are those? Initial and subsequent. So it's not like you have to highlight the whole paragraph, but I think you get where I'm going with this. Is that correct? You want this stuff to jump out at you when you turn to the page and have to look up, oh yeah, okay, so we've got new patient, established patient, initial, and subsequent. If I say to you, what's a new patient, Daniel, you should be able to tell me that's an office visit. If I say to you that it's going to be a subsequent visit, you should be able to tell me right off that's a hospital visit. Okay? And then, where does all of this nature of the work take place? Hi, Anita.
Hi. Sorry, Anthony.
We are on page 4 in your CPT book. I'll give you a minute to get started.
Yeah, sure.
So if we want to know the nature of the work is going to vary. And how is it going to vary? By service, place of service, and patient status. So as I go throughout this lecture, through this presentation, if you can try and follow along in your guidelines as well as your textbook. So when I say to you page 429 in your textbook and page 4 in your CPT book, is that helping you? Okay. That's fine. For those of you it helps fine. If it doesn't, that's fine. Choose one or the other. Okay? If the textbook is easier for you to follow along with and then take your notes and put them in your CPT book, fine. What I'm trying to show you by having the two books side by side is that your notes in your textbook can be transferred to your CPT book because the text, the wording in your textbook are your guidelines. So, Anita, we're on page 4 in your CPT book and page 429 in your textbook. All right, so your job is to code what is documented in the medical record. And we've talked about this in the diagnosis book. Basically, your job is to code what is documented in the medical record. When you have incomplete information that is provided, you should ask the physician or the physician assistant to provide additional details. It is not appropriate for us as coders to assume beyond the information that is provided to us. The medical record is the documentation that supports the claim going out the door. So our job is to optimize, never maximize. Optimize means to get the most out of. Maximize means to increase or make as great as possible, which means we accurately report documented services. So all of the reimbursement that is provided for the services and procedures that are actually delivered to the patient is based on the documentation that we receive from the provider. It is a crime to code for services that are not provided. It is fraud to bill for services that were never rendered. So what you will find in Chapter 15 is the E&M section, and it will report the physician services. This is one of the most frequently used sections in the CPT book. And as you see, it is the very first section. So this is where we will find the delivery of services to the patients. What types of services could they be? Nursing home, extended care facility, inpatient, outpatient, physician offices. What you will find is that you will have subsections by type of service. What are the types of service? And we just went over that in your guidelines. Office, hospital, and consultations. What are the three factors of your E&M codes? It is the place of service, the type of service, and the patient status. Okay? So what is the place of service? The bottom of page 429 in your textbook. The place of service explains the setting of the service. So what are the settings? Office, emergency department, nursing home. What is your type of service? Over on page 430, type of service. Type of service, office visit, admissions, consultations, and prolonged services. Your patient status. You have 4 status types. We have new patient, we have established patient, we have outpatient, and inpatient. So what is a new patient? A new patient is anyone who has not received any professional service in the last 3 years from the same physician or from another physician of the exact same specialty and subspecialty and in the same group. Your new patients are more labor-intensive for your physician and your staff. Why do you think that would be, Darcy?
Because they have to do all of the examinations, history.
You're right. They
Look
have to
at
help the
previous
patient.
records.
Yep. Help the patient with the paperwork, do the vitals, do the pre-consult. Why are they there to see the doctor? Yes, more time intensive. An established patient is anyone who has received professional services in the last 3 years from the same physician or another physician of exact same specialty and subspecialty in the same group. This is where your medical record is available with the current and relevant information. All right, an outpatient. An outpatient is one who has not been formally admitted to a healthcare facility. So if a patient receives service at a clinic or a same-day surgery center, that's an outpatient. If the patient is admitted to observation status, that is an outpatient. An inpatient, one who has been formally admitted to a healthcare facility, such as a hospital or a nursing facility. The attending physician would dictate the admission orders, the H&P, and the request for any consultations. Okay, page 432. Various levels of the E&M service. The first is the nature of the presenting problem. This is your foundation. The second is the skill that's required to provide the service. The third is the time spent, if 50% of total time is counseling or coordination of care. The fourth is the level of knowledge necessary to treat the patient. Fifth, effort required and assumed. And sixth, responsibility required. All of these are based on the documented evidence that we find in that patient's medical record. Then we have the key components, or I should say these levels are then divided based on key components and contributory factors. So every encounter will vary or have a varying amount of key components and contributing factors. So, encounters. When we have an encounter, when you have more of each component and factor, you're going to have a higher level of service. When you have less of a component and factor, you're going to have a lower level of service. So let me give you an example for that. So let's say you go into your primary care physician and you have a cough and a runny nose. So would you say that's low level or high level? Pretty low level. But what if you go in and you have cut your finger, you're bleeding from the side of your head, you've got abdominal pain? Low level or high level?
High.
High level. So think about your encounters and try to think about what they would be, low level or high level. So if I go into an emergency room with an exacerbation of asthma, is that considered low level or high level?
High. High, I guess.
It's actually high level because it's an acute exacerbation. How about someone who walks in with tree sticking out of their side? They use the chainsaw and it kicked up and went right through the side. High level, right? Okay, someone comes in, they have some shattered glass side of their head. Low or high? Still pretty high level because you don't know the extent of the shards of glass. If there's some blood, you've got to clean it up. So think about it. More time intensive is going to be a little higher level. All right? You guys can laugh at this one. Over the summer, I had a garden shear accident. I like to garden with bare feet. I don't like to wear shoes. And I was cutting whatever. I don't even remember at the time. And I was done. I'd put them on the table. I was getting ready to go inside, put them away. I picked them up just right, and they fell out of my hand and cut my foot. So first thing I did was I sat down, elevated my foot, had my husband go get a towel to wrap around my foot. Blood was gushing everywhere. What's that? Low level or high level?
High level.
It's a high level to assess the damage, the trauma. Then the wound itself was low level because once I was able to stop the bleeding and get to the emergency room, they were able to, I had it pretty much all well taken care of. I just had to get a stupid tetanus shot and they, you know.
If you had actually cut something off, it would have been high level.
It would have been, right.
And it's low level.
Right. Yeah, I did a pretty good job. I didn't hit any nerves or create any damage like that, but I had to stay off of it for a little bit. Stupid mistake. Picked them up, they fell out of my hands.
I've done the same thing myself.
Yeah. So when you're thinking about encounters, think about the work involved in that encounter. All right, so key components. Your key components are the history, the exam, and the medical decision making. So to some extent, you will have each of these key components in every patient encounter that you have. So we're on page 432 in your textbook. Okay, so key component. We'll use the example of the emergency room, okay? What's the history? So what happened? The examination. How are they examining it? And then the medical decision making. What has to be done? Well, we got to clean it out. Maybe debride it a little bit. Stop the bleeding. Suture it up. Make sure it's all clean. Okay, that's pretty simple. Okay, contributory factors. These are the conditions that help the physician determine the extent of the history, exam, and decision making required to treat the patient. So there are 4 contributory factors. Counseling, coordination of care, the nature of the presenting complaint, and the time. Some or all of these may be relevant in a given patient encounter. So did they have to counsel me on my foot? No. Coordination of care? No, they didn't have to involve anyone else but the nurse. What was the nature of the presenting problem? I punctured my foot, ended up with a 3-inch gash, a couple inches deep. Just had to clean it out. The nurse was able to do most of it. I think the doctor spent all of 10 minutes with me, if that. All right, so what's 4 elements of a history? Over on page 433, 4 elements of a history. So we have the chief complaint. All right, what's the chief complaint? I have a gash in my foot. History of the present illness. Well, what was I doing? I picked up the garden shears to put them away. They fell out of my hand. They punctured my foot. I elevated the foot immediately to try and, stop the bleeding. Review of systems. So what kind of review of systems do you think the doctor is going to do? What is a review of system? Anyone can tell me? It's an inventory of the body system obtained through a series of questions to identify signs and or symptoms that may be experiencing or has experienced. So we're over on page 434 and 435. Okay, so we have the chief complaint. I punctured my foot. The history of the present illness. As I said to you, what happened, it ends up being what we call a chronicle description of the development of the present illness. So what was the first sign or symptom from the previous encounter to the present? And underneath that HPI, some of the things we want to ask are, what is the location? What's the quality? Is it burning or throbbing? What is the severity on a scale of 0 to 10? What's the intensity? What is their duration? How long has it been? Timing. Has it been throughout the day or continuously? Or at night or in the morning? What's the context? Under what circumstance does this occur or hurt? Modifying factors. Is it better when it's lying down or worse when you're bending? And then are there any other associated signs and symptoms? Any weakness? What else is present related to the chief complaint? If you think about all of the encounters that you have with physicians, whether it's your primary, your ear, nose, and throat, your OBGYN, your asthma and allergy, you go through all of this, don't you? But we never think of it that way. We think that it's just being asked the same old thing over and over, and the first person didn't listen, so that's why the second person's asking the exact same thing. Right? So then they have to do a review of systems. So if I just hurt my foot, what system do you think they're going to review? They're going to review just my foot. Do you think they're going to ask about gastrointestinal, genitourinary, respiratory, cardiovascular, ears, nose, and mouth, eyes?
Probably not, unless maybe you had an intense history of it.
Right. So as long as it's not related to the present illness, that the only thing they're going to do for a review of systems might be the musculoskeletal. So have I affected the range of motion at all? Can I walk on it? Is it stiff? Is it hurt? All right. Now, they might check ear, nose, mouth, or throat. If I forgot to mention I might have fallen. They might throw in there constitutional, so weakness. Is there a weakness since did I lose too much blood? I doubt it, but. All right, integumentary, they would turn the page, 436. They would check the skin around the cut, the puncture. Neurological, they might check neurological. They might check the bottom of the foot, see if I did anything to the nerves around that area. Endocrine, hematologic, allergic, psychiatric. So based on the reason for the encounter would dictate what type of review of systems. So if someone comes in from a trauma, from an accident, pretty sure you're going to do all review of systems, all system review. If someone's coming just for ear, nose, and throat, cough, sneezing, stuffy ears, you might have respiratory, allergy, ear, nose, mouth, eyes, okay? So think of it that way. What is the person coming in for? What system does it relate to? Keep this in mind. What does the encounter relate to what system? So if it's heart, probably cardiovascular, and what else? Respiratory. Okay. Then we have past family and or social history, PFSH. Okay? This is important because we want to know what is the past history with the patient's past experiences with illness, operations, injuries, treatments that may include significant information about the current injury. So how many times have I cut my foot before? Well, if they look at my foot and they only see the one scar, it's pretty good to say I've not done it very often. But if, I have on shorts and my legs are all scarred up, they might ask me, have you had other experiences? Social history is an age-appropriate review of past and current activities. Are you married, currently employed, occupation, use of drugs, alcohol, and tobacco. And then family history. Is there a family history of puncture wounds, diseases, health status of parents and siblings? So all of this goes into an encounter, which you probably never even thought twice about before tonight. But this is what happens just about every time you go for an encounter, especially if it's a new patient encounter. So if your primary care refers you to a specialist, you will probably go through a lot of these questions. If you're an established patient, the most they probably ask is, has anything changed from last time? Anything new we need to know about? Okay, everyone follow so far?
Yeah.
All right. Who said kinda?
Yeah, I'm good.
Okay. All right, so chief complaint. I think I've hit upon it, but we're going to review it again because it's important. Chief complaint is what, Shanna?
Why you go there?
Right, the reason for the encounter, why you go there. And we usually write it in the patient's own words, and we document it in the medical record for each encounter. So I may have come in today for my asthma, but next week I'm coming in because I have a rope burn on my leg. So every encounter, there's a reason for the encounter. And it is required for all levels of service. It may not be stated as CC, but it can be inferred from your documentation. All right, the HPI, the history of present illness. This is a description of the development of the current illness. So what's the date of onset? The patient will describe to us what is the development. And if the patient cannot answer for themselves, a parent, a guardian, or any other person may be able to provide information. We end up with 8 elements in your HPI. And the provider must document. So here's some dialogue. We're just going to go back and forth, just so you get a little clearer picture. This is development of a chief complaint of abdominal pain. The patient comes in, tells the doctor it started Thursday night and it was mild. During the night, it got worse. Friday morning, I went to work, but I had to leave. The pain got so bad. All right. The physician asks, what's the location? Well, the pain is in the lower left side, a little toward the back. All right. What is the quality? Is the pain sharp and dull and pressure? Is there a burning sensation? The patient will say something like, pain is really sharp and constant. All right. What is the severity on a scale of 1 to 10? Is it 10 intense, moderate, or mild? The pain is terrible. Worst pain I have ever had. It's intense. All right. What's the duration? How long has this pain been present? The pain is going on 3 days now. And what is the timing? The pain is present all the time. It doesn't go away. All right. What is the context? So when does it hurt the most? Is there a correlation to a specific activity, like climbing the stairs? No, the pain is just there. It doesn't matter what I am doing. Are there any modifying factors? Does anything make it better or make it worse? No, nothing I do makes it any better or worse. Aspirin is taken, but I don't have any relief. Do you have any associated signs and symptoms that are relating to this problem? Does anything else feel different when the pain is present? Yes, I have nausea when the pain is at its worst. Okay? So everyone follow me with that? Okay. So let's talk about the review of systems then. You have organ systems. Respiratory and cardiovascular. There are 14 elements in the report in the review of systems. The extent of the report of systems, review of systems, depends on the chief complaint. And we went over that with my example. So you do not usually review musculoskeletal system for a chief complaint of chest pain. And a patient who has sustained trauma from an auto accident and can't discern difference. So there has to be medical necessity for the number of organ systems that are inventoried, and it must be implied or documented. Now the systems that are in your review of systems, we talked about those. If you look back on page 435 and 436, you'll see the constitutional, the eyes, the ears, the cardiovascular, respiratory is an organ system, gastrointestinal, genitourinary, musculoskeletal, and tegumentary, those are all organ systems. So genitourinary system, you might have painful urination, results of female reproductive tests. With gastrointestinal, it could be something about appetite and nausea or rectal bleeding. In tegumentary, it could be presence of rashes, eruptions, and jaundice. We have the neurological, the psychiatric, the endocrine, the hematologic, and the allergic. These are all organ systems. Then your past family and your social history. This also contains the relevant information that I just reviewed with you earlier. Major illnesses, operations, hospitalizations, allergies, immunizations. Then your social history will also contain information about your sexual history and any other relevant social factors. Past and present medications. Your family history, the health status of your family members, parents, siblings, children, and any family history items related to the chief complaint. So now we get on to the 4 levels of history over on page 437. So there are 4 levels of history. We have the problem focus, the expanded problem focus, the detailed, and the comprehensive. So as I said earlier, every encounter you want to pay attention and see, is it going to be low level or high level? And these 4 levels help you determine low to high. So a problem focused, right there on page 437 in your textbook, a problem focused, you have a brief history that is focused solely on the chief complaint. A brief HPI, no review of systems, no past family social history, and a brief history that includes 1 to 3 of the 8 elements of the HPI. So, simple, runny nose, how long has it been going on? No review of systems, but they might actually do an ear, nose, and throat review. No past family social history. If it's an established patient, they might look in your chart and see how long, how often you come in. If you're a new patient, they might ask you real briefly. Expanded problem, a brief history focused on chief complaint. A brief HPI, less than 3 of the 8 elements, or 1 to 2 chronic problems. A review of system as it pertains to that presenting problem, and no past family social history. A detailed history, you'll have the extended history, extended HPI. With the HPI, you may have 4 or more of the 8 elements and 3 or more chronic conditions. You also will have an extended review of systems and a pertinent past family social history. So do you all see how as we go higher in the histories, the more information we will need to come to some type of medical decision making for a patient? Okay. So comprehensive, extended history, extended HPI, complete review of systems, and complete past family social history. When we talk about a comprehensive history, we're talking about someone who has had trauma in their life. Some type of trauma. And this is time intensive. You don't see a lot of comprehensive history unless usually it is a trauma. Work-related, personal injury, trauma-related. If you look on page 438, you will see a figure 15-4. It talks about the 4 levels, and it gives you a little graph of what is needed underneath each one. Remember also in the front of your CPT book, you have that section that has the E&M tables for you. It's on Roman numeral 22, 23, and 24, right before the E&M section in your CPT book. Okay? Everyone able to locate those so they know where they are? All right. So moving on to the examination on page 439 in your textbook. The examination, there are 4 levels of examination. Same thing as before. Problem focused. Problem focused is the affected body area and or organ system. In your 1995 guidelines, there are 10 body areas. In your 1995 guidelines, there are 12 organ systems. Today, we still use the 95 and 97 guidelines that Medicare put out. Excuse me. And you'll notice that part of that information is included here in your CPT book. The expanded problem focus exam is a limited exam. It's usually the affected body area and or the organ system. Other related body area and or organ system, which is often vitals or general appearance of the patient. A detailed exam would be an extended examination of the affected body or area and or related organ system. Your comprehensive exam, again, complete single specialty or complete multi-system exam. So, ear, nose, and throat. Cardiovascular. So on page 440, figure 15-5, again gives you another graph and breakdown of the 4 levels of each exam. What you want to remember is that the extent of the exam depends on the needs of the patient and expert judgment of the physician. If it isn't documented, it didn't happen. How many times have you heard me say that throughout class? If it isn't documented, it didn't happen. And if it may have happened, but you can't bill for it unless you documented it. So, just because it happened doesn't mean it did because you didn't document it. The extent of the exam must be documented in the medical record. Then we have MDM, medical decision making. Medical decision making complexity. The level of the MDM is significantly different for a person who has a chest cold versus a person who has severe chest pain. Why would that be, Daniel?
With the chest colds, he knows what it is and it's something that he can deal with. But with the severe chest pain, there's a lot of investigation that has to be done with it. At least some investigation.
Exactly. Someone who comes in with severe chest pain is going to be treated far quicker than someone who comes in with a chest cold. Unless, of course, this person who has a chest cold goes into anaphylactic shock, and then we have 2 separate severe intent situations. So the level of medical decision making on each one is lower, one is higher. So, as we have learned already, the different levels of your exams, you also have elements to your medical decision making. And there are 3 elements to your level of decision making. The number 1 is the number of diagnoses or management options. Is it minimal, limited, moderate, or extensive? And you're going to see that this is the theme throughout these elements. Number 2, the amount and or complexity of data to be reviewed by the physician. Is it minimal, limited, moderate, or extensive? And then 3, risk of complications of death, morbidity, or mortality. Minimal, low, moderate, or high. So now we have 4 levels of medical decision making. Straightforward, low, moderate, and high. So you see the theme that we have going on here? We have 4 levels. 4 levels of exams, 4 levels of encounters, 4 levels of medical decision making. The straightforward is where the number of diagnoses or management options are minimal. The amount and or complexity of data is minimal, or none. And the risk of complications or death are minimal. Your low complexity, again, based on the number of diagnoses or management options, the amount and or complexity of data, and the risk of complications or death are low. So low complexity would be limited and low. Your moderate complexity, the number of diagnosis or management options are multiple. The amount and or complexity of data is moderate. And the risk of complications or death are moderate. High complexity, number of diagnosis or management options are extensive. Amount and complexity of data is extensive. And risk of complications or death are high. Your management options on page 444 are based on the number of possible diagnoses, whether they are definitive or differential, and the various ways that the condition can be treated. Then the data reviewed and ordered. So if we have laboratory, radiology, any test and procedure results that are documented in the medical record, if it's been reviewed or ordered. The more data the doctor's reviewing, the more complex. When we have results, they need to be documented in the medical record. So if a physician sees the hemoglobin is within normal limits, they need to make that note in the chart because they reviewed it. If they reviewed the chest x-ray and it's negative, they need to write in the medical record, chest x-ray negative. Old medical records are considered data from others that may be requested and reviewed. Risks, what are risks? Over on page 445, risks are of morbidity, which is a poor outcome, complications, or mortality, which is death with problem and or treatment. So what are the risks? The risks are of poor outcome and death. We have other factors, other diseases, or factors that affect the risks, such as diabetes and extreme age. And then urgency that relates to the risk, such as a myocardial infarction or a ruptured appendix. And guess what? We have 4 levels of risk: minimal, low, moderate, and high. So, if I have a wasp bite, what is that considered? It would be minimal, and it would be self-limited. If I have multiple wasp bites, it's considered low. I have several minimal levels or one level that is more than minimal. One or more chronic illnesses. Diabetes. 2 or more stable but chronic illnesses. Controlled high blood pressure and diabetes. These are both considered moderate. So 1 or more chronic illness, 2 or more stable but chronic illnesses would be considered moderate. A moderate risk level is an undiagnosed condition with unknown prognosis, such as a breast lump or an acute illness or pneumonia. A high risk level would be 1 or more chronic illness with a current severe exacerbation, such as malignant hypertension and uncontrolled diabetes. Illness or injury that is life-threatening, such as myocardial infarction or cardiac arrest, is considered a high risk level. And you will see on figure 15-6, it gives you a summary of elements for each level of the medical decision making. So, just to review the three key components, it is our history, our exam, and our medical decision making. And the key component, the first one of the history, you have 4 levels of history. And the elements that determine the level of the patient history is your chief complaint, your HPI, your review of systems, and your past family social history. Then we move on to the 4 levels of that history, which could be problem-focused, expanded problem-focused, detailed, and comprehensive. The second component is examination. This is the objective exam of the patient, and we have 4 levels: problem-focused, expanded problem-focused, detailed, and comprehensive. Then we have the medical decision making, which is the number of diagnoses or management options, the data that needs to be reviewed, and the risks from the current encounter to the next visit. Just to remind you, there are 4 levels of medical decision making: straightforward, low, moderate, and high. And then there are some other factors. 3 other factors are considered in establishing the level of service, and these are called the contributory factors. Your contributory factors, as I mentioned earlier in the class, are counseling, coordination of care, and the nature of the presenting problem. So, what is counseling? On page 450 in your textbook. Counseling is face-to-face. This may be provided to the patient or family members. It's where we discuss the diagnosis, test results, impressions, and recommendations. And the medical documentation must support that more than 50% of the visit was counseling. The second one is coordination of care. This is also face-to-face. This is work that is done on behalf of the patient by the physician to provide the care. So, such as making arrangements for admission to a rehab hospital or a nursing facility. And then the nature of the presenting problem. What type of problem patient presents to the physician with, and what is the foundation upon which the key components are factored. Any questions so far? Okay. Page 451 in your textbook, types of presenting problem. We have minimal, self-limiting, low, moderate, and high. A minimal presenting problem may not require a physician, such as a dressing change or removal of an uncomplicated suture. Self-limiting presenting problem. Self-limiting problems are minor and with a good outcome predicted. So someone who has a sore throat or a slightly irritated skin tag. A low presenting problem, without treatment, low risk. So a middle-aged healthy male with an upper respiratory infection. A moderate presenting problem, without treatment or moderate risk, an elderly male with pneumonia. A high presenting problem without treatment and high risk, an elderly male in very poor health with severe pneumonia. And then time. Direct face-to-face, physician and patient together, whether it's in a clinic visit or at a bedside in a hospital. This is where your time-based codes would come in, and it's documented in the record, beginning time and end time. And then if the total time spent indicates 50% or more, probably it was counseling and coordination of care. If there is a physician on the unit and floor, the time that is spent by the physician on the patient's floor or unit is also at the patient's bedside. So from the time that physician walks on the ward and goes to review the patient records at the chart at the desk and then goes into the patient is all documented as part of that one visit to see that one patient. All right, your E&M codes. If you look on page 453, figure 15.7. All right, this is what it looks like in your E&M section. So you'll see that you have the category. You see that you have the three key components. You have the place of service, you have the contributory factors, the number of key components required, the category of the patient status, and the place of service. So when you use your E&M codes, the codes are grouped by type and place of service, which we said earlier are your consultation, your office visit, and your hospital admission. You will see that there are different codes for various levels of service. They range from 99201 to 99205, and these are for your new patients in the office or other outpatient setting. Your established patients, 99211 through 99215. The 99211s may not require a physician. There is not a code in the new patient category because all new patients are seen by a physician. Over on page 457 in your textbook. Hospital observation status. Not officially admitted to a hospital. The patient is not ill enough to admit, but is too ill not to be monitored. You want to make sure you read the notes at the beginning of the subsection underneath hospital observation status, because your observation services are not codes for inpatient services. Your observation admission can only be reported for the first day of the service by that admitting physician. And when the patient is admitted with observation status and discharged on the same day, they have specific codes that they want you to use for observation or inpatient care services category. And that would be your codes 99234 through 99236. Medicare actually has time constraints for these codes, so knowing what those guidelines say are important. When a patient in the hospital overnight for observation but less than 48 hours, the first day code would be reported using 99218 through 99220. The second day would be 99217, which is the observation care discharge service. If your observation stay is longer than 48 hours, you have a set of codes for the initial observation care, a set of codes for subsequent observation care, and a third code for observation care discharge. So the initial observation care, the codes are 99218 through 99220. The subsequent observation care codes, 99224 through 99226. And then your third day observation care discharge, 99217. And if you're interested in where those are in your CPT book, it should be 13, 14, and 15. Still on page 457 in your textbook, the initial observation care. This is the beginning of the observation care service. It does not require a specific hospital unit. It can be a regular bed. The status is specifically written as observation. The services immediately prior to admission are bundled into that observation service. So let's say, for example, I have an office visit prior to observation. But that is going to be bundled into that observation service if it is performed on the same date of service. Your hospital inpatient services. Over on page 459 in your textbook. This is where someone is formally admitted to a hospital setting. It's where total all day and night on a given date of service. If there's a partial, all day and no night, or all night and no day, or a variation, and then patients starting in observation, then they're admitted, the services are going to be bundled into that initial hospital service. The types of physician status. Over on page 461. Types of physician status, page 461 in your textbook. An attending physician, second paragraph. An attending is a primary or admitting physician. A consultant is a physician whose opinion and or advice requested by another physician. There is specific criteria required. Types of care. You might have concurrent care given to a patient by more than one physician. So if we have a pulmonologist and a cardiologist both treating a patient for different conditions at the same time, that is considered concurrent care. You then have two types of hospital inpatient services. On page 459, you have initial and subsequent. The initial hospital care is where the first service will include the admission. Blah, blah, blah. Sorry about that. Admission. Where the initial paperwork and initial plans and orders are given. This is used only once for each admission by the admitting physician. I don't know what is happening with me tonight. I can't speak. And then other physicians would bill consultation or subsequent hospital care as appropriate. For subsequent hospital care, over on page 460, this is after the initial service. So a physician would review the patient's interval progress using documentation and information received from the nursing staff, examination of the patient, and then 2 or 3 key components are met. Your hospital discharge services, over on page 461 at the bottom. This is the final day of hospital stay when the patient was in hospital for more than one day. The documentation indicates the final patient status. The codes are based on time. Time does not need to be continuous. Beginning and ending time or total time must be documented to assign extended discharge code. And then the final status of the patient would be, okay, what's the condition? What medications are we sending them home with? Plan for return to see the physician. How has the hospital stay progressed? What's the discharge? Are they going home or to a nursing facility? So the final status of the patient must be documented on the discharge services. Now, some things that are unique to discharge codes. Only the attending physician can use a discharge code, and that code is going to be based on time spent in the service. So they put the beginning time and the ending time, and it has to be documented, and the total time spent, or use the lowest level code. Your consultation services over on page 462. One physician would request another physician's opinion, and it can be either inpatient or outpatient. It would be reported as an outpatient or an inpatient consultation. You can only have one consult by a consultant per hospital admission. The consultant would provide a report of the opinion and or advice to the doctor who ordered it, and it must be documented in the medical record. If we have third-party payer consultations, this is where there might be a request to confirm past medical treatment, current condition, or the payers may request prior to approving procedure. You want to bill using the inpatient or outpatient consult codes. Apply a 32 modifier, which is the third mandated service. Your outpatient consults include those that are provided in the emergency department. And as of January 1st, 2010, payment for Medicare consults are no longer reimbursed. You would have to report it with the E&M code as an inpatient or an outpatient. Your emergency department services are the same for new and established patients, but the codes are 99281 through 99288. So if you're in your assignment, you see emergency department, make sure you go to the emergency department section of the E&M. Do not go to new or established patient. The ED is also known as the ER. It must be open 24 hours a day, unscheduled visits, and it's usually provided by emergency room staff. Your critical care and ED codes, the ED services often require additional codes from the critical care services. This is where someone might have multiple organ failure. A critical care service is provided to patients who are in life-threatening situations. The type of service, the type of critical care will depend on the condition that's present on arrival in the emergency department. And your codes for critical care are going to be based on time. So these are time-based. And critical care services are over on page 469 in your textbook. So the codes are time-based, and they're usually total time less than 30 minutes are reported with an appropriate E&M code. Your critical care services on page 470 goes over the codes, the length of time, and age of patients. Your nursing facility services on 471. These are non-hospital settings with professional medical staff. These people usually provide continuous healthcare services to patients who are not acutely ill. And these are formally known as your skilled nursing facilities, your intermediate care facilities, and your long-term care facility. Your comprehensive nursing facility assessment is provided at time of admission. This would be the initial visit by the physician. There's also providing periodically during a patient's stay in the facility. There are regulations that an assessment also be done. This would be using code 99318. And subsequent nursing facility care codes are used if a patient is stable or the condition is unchanged. On page 474, your rest home, domiciliary, custodial care services. These are healthcare services that are not available on site. The types of services provided here are lodging, meals, supervision, personal care, leisure activities. Residents cannot live independently, and you would use codes for new and established patients. There are home care plan oversight services. These apply to anyone not in home health, hospice, or nursing facility. These are usually reported once a month, and the codes are based on time. Your home services. This is where the care is provided in the patient's home. The services are based on history, physical exam, and medical decision making. You also have codes for new or established patients. And the home is considered the patient's private residence, not an assisted care facility. The prolonged services, over on page 475 in your textbook. The prolonged services are your time-based codes for direct and non-direct services. The codes for the first 30 to 74 minutes, then there are codes for each additional 30 minutes. If it is less than 30 minutes, do not report service as prolonged. Use an add-on code. Your standby services over at the bottom of page 476 in your textbook. If the physician is not caring for other patient, you would use code 99360. Physician standing by for only that patient if needed. And even if no care was provided to a patient during standby time, the physician would report and bill the service. But all of this must be documented in the medical record. So there is such thing as standby service. And if the physician is literally standing by, they would use code 99360. Your case management services over on page 477. This is used to report coordination of care with other health professionals and anticoagulant management. The anticoagulant management is an outpatient management of the warfarin therapy, also known as Coumadin. Your first 90 days and then subsequent 90 days, and then we have any period less than 60 days is not reported. Also underneath the case management services, you'll see medical team conferences. This will be your face-to-face with patient and or family, without patient and or family, and without patient and or family. So one where the participation by the physician is 30 minutes or more. The other one is participation by a non-physician, qualified health professional, 30 minutes or more. Your care plan oversight services on page 478 in your textbook. These are used to report supervision of patient care under your home, domiciliary, or equivalent environment. These are reported for a 30-day period. So you just do at 30 days, report it. They are reported in increments of 15 to 29 minutes. or 30 minutes or more. Your preventative medicine services. These are used to report services when a patient is not currently ill, so someone who has an annual checkup. These codes are divided on new or established patient status and patient age. If there is a significant problem that is encountered during the preventative exam, the E&M is also reported and the modifier 25 is added to that E&M code. The individual and group counseling codes, this is a patient is seen specifically to promote health. The codes are based on time, individual or group, and physician review of assessment data. If there's behavior change interventions for individuals, such as smoking, tobacco, or alcohol, that's where those codes come in. Your non-face-to-face services, page 479. This would be used to report your telephone services, your online report services, reporting interprofessional telephone and internet consultations, services that are provided for life or disability insurance. Your newborn care and neonatal pediatric over on page 480 and 481. You have multiple subheadings under here: newborn care, delivery, pediatric, inpatient neonatal, inpatient pediatric, and initial and continuing intensive care services. For the newborn care services, your initial and subsequent care in and other than hospital or birthing center, these would be used for your normal newborn infant per day for the E&M services. Your 99463 code, the initial hospital and birthing center when admission and discharge is the same day. Your delivery and birthing room attendance and resuscitation, codes 99464 through 99465. The 99464 code is used for attendance at delivery. It is documented, request by attending in medical record, and it provides initial stabilization. The 99465 code is resuscitation and ventilation. So intubation here is not included. Your neonatal and pediatric critical care services. This would be things like the critical care patient transport. The patient is critically ill or injured 24 months or younger. You would use codes 99466 through 99480. Pay attention to these because these are timed codes. You have the first 30 to 74 minutes, and then the next code is each additional 30 minutes. These also report interfacility transport as well as face-to-face service. Your inpatient neonatal critical care services are the 99468 and the 99469. These are divided by the initial day and subsequent day. If you have a critically ill neonate, that is someone aged 28 days or younger. Your inpatient critical care services, also you have 99471 through 99476. The inpatient services, and these are divided by age, 29 days through 24 months, 2 through 5 years, and then they are also subdivided by day. Is it initial or is it subsequent? Then you have your initial and continuing intensive care services. This is where they are in the hospital care. You have neonate, 28 days of age or younger. Then you have other codes that are divided by the birth weight. You have VLBW, which is very low birth weight. You have low birth weight and normal birth weight. LBW, low birth weight. These codes are also subdivided on the day. Is it initial or is it subsequent? And then other E&M services, we've heard about this early on, are your 99 codes. So 99499 is seldom used, and it's where we would have to have a written report with the submission. All right, any questions? All right. Why don't we take just about 5 minutes, and we're going to come back and go over some of the chapter exercises and the theory and practical at the end of the chapter. How's that sound?